diagnosis of myelodysplastic syndromes have evolved over time because myelodysplastic syndromes occur largely in older patients. For a long time, this was somewhat of a neglected disorder, largely because we did not have many active therapies. So many times the patients would have some mild anemia, which is the most common manifestation of MDS. And many physicians or even some hematologists would decide against doing a bone marrow biopsy because they think of it as an invasive procedure and there was not much you could do about it. This has changed substantially over the last 10, 15 years, I would say, because now we have more effective therapies. We understand that establishing diagnosis is very important. And also, in all honesty, bone marrow biopsy is not really a very difficult procedure. We do it very routinely without significant problems in the vast majority of patients. So the first step in diagnosis generally involves ruling out other causes of low blood counts and cytopenias. So those could be vitamin deficiencies, other medications, other clinical conditions such as immune conditions, other blood conditions. All of these could mimic MDS. Eventually, the diagnosis will also, in some situations, include ruling out some rare abnormalities such as paroxysmal nocturnal hemoglobinuria or copper deficiency, things like that. Once all of these are ruled out, generally the next step is doing a bone marrow biopsy, and the diagnosis is often established based on the bone marrow biopsy in conjunction with reviewing the bone marrow smear. So this is how usually the diagnosis of MDS is established. This is usually done by a hematologist after the patient is referred from their primary care physician, who usually would be the first person to spot the low blood counts. Sometimes the patients will not have any symptoms. The blood counts are just picked up on a routine screening or physical exam, blood work. And sometimes the patient could have significant symptoms related to bleeding from the low platelets, infections from the low neutrophils, or symptoms of anemia related to the low hemoglobin. After establishing the diagnosis of myelodysplastic syndromes, usually the attention will turn into the risk stratification. Risk stratification or prognostication is extremely important in myelodysplastic syndromes because those conditions occur on a wide spectrum in terms of the outcomes of patients. So some patients can live for many years with minimal symptoms in which you just check their blood counts every few months, all the way to very aggressive forms that almost resemble acute myeloid leukemia in terms of complications related to infections and bleeding and short survival, which could be in the most aggressive forms of MDS in the absence of treatment of few months to less than a year. So because the natural history is highly variable, establishing the specific risk status of the patient is very important. So over the years, there has been multiple prognostic scoring systems that were established. One of the very first ones that have been used for a long time is the International Prognostic Scoring System, the IPSS. This was described in 1997 in publication in Blood and has been really the de facto standard of care in terms of prognostication. For a long time, it was used not only to counsel patients, but also in terms of enrollment in clinical trials and even approvals for some of the medications by the FDA and other agencies. However, over time, we realized that the IPSS suffers from certain problems. For example, it overestimated the prognostic impact of the blast count and underestimated the prognostic impact of the karyotypic or cytogenetic abnormalities. And because of that and other considerations, a new version of the IPSS was developed, which was called the revised IPSSR or IPSSR. Basically, this was published in 2012 and gradually has become, I think, the most commonly used prognostic scoring system. It's now being used for clinical trials, for decision making. It's somewhat more accurate in terms of predicting the different prognostic group. There are multiple other prognostic scores that are out there. One of them is WHO-based prognostic scoring system and the MDS prognostic scoring system. The MD Anderson prognostic scoring system. And I think ultimately, whichever one of those you are using, The bottom line currently is really to classify the patients in one of two big groups, either higher risk or lower risk. And the reason for that is the goals of care are very different. For higher risk MDS, which would include in the revised IPSS the very high and high risk categories, the goals of care basically revolve around changing the natural history of the disease, trying to cure the patient, if possible, with a bone marrow transplantation. While in lower risk MDS, which is usually defined by the revised international prognostic scoring system, risk categories of low and very low, in those patients, the quality of life is the focus, because generally we cannot cure those patients. We generally don't do a bone marrow transplantation for those patients because the risks of the procedure that outweigh the benefit. And the goal is to minimize transfusions, reduce risk of hospitalizations and infections and such. And then you have one group that is the intermediate risk group within the revised IPSS. And those patients, there are different ways to treat them basically, and they could be treated as higher risk or lower risk depending on a number of factors that we consider, both based on the blood work as well as clinical variables in terms of which scoring system to use. And I think people tend to use several scoring systems. I think all of them have certain caveats along the lines of what we mentioned. I think one of the bigger caveats of all the current scoring systems is that none of them include the molecular parameters that we are understanding more and more that they can affect prognosis significantly. For example, having a TP53 mutation, we are now recognizing more and more that having those mutations will worsen the survival significantly in patients with MDS. However, it's not part of any of the current prognostic scoring systems. There are ongoing efforts to include that in what we call molecularly based IPSS or molecularly based revised IPSS. But until that's available, I think you have to apply other aspects in your estimation, such as the comorbidities of the patient, what are medical conditions that they have, because those are often not included in the prognostic scoring systems. So the one I tend to use the most is the revised IPSS. In some patients, basically with the revised IPSS, such as the intermediate risk group, as I mentioned, those patients could sometimes behave like higher risk or lower risk. So in those patients, I tend to subcategorize them using the WHO-based scoring system. And sometimes the clinical trials will mandate you to use. Some of the clinical trials are still using the IPSS. So in those situations, we calculate that as well. But overall, I would say the revised IPSS is the most commonly used one in my practice and suspect in most settings.